Croeso to Wrexham News. I'm Councillor Carrie Harper.
And Councillor Marc Jones.
And today we're talking to Mabon ap Gwynfor, who is the MS for Dwyfor Meirionnydd and also Plaid Cymru's health spokesperson. So health is something we've talked about a lot on this podcast, whether it's in dentistry, waiting times, Penley Hospital. You know, this is something that's impacting people's quality of life locally and right across Wales. And it's fair to say that most people think the NHS is in quite a mess after 26 years of Labour. How are we going to fix it?
Yeah, the good news is that it is fixable. It can be done. The problem is that we've got lack of leadership from the top, from the government. So the government are setting out far too many targets, for instance, and the clinicians and the managers in the NHS don't really know which one to go for. So they don't go for any of them, or they go for their own plans, and they're not investing the money in the right places. So instead of investing in preventative measures, that preventative agenda is key, stopping people from getting ill in the first place, or stopping people from getting worse. That's where we should be putting resources, and into community healthcare as well. Instead of that, we're seeing money being thrown at the front line, trying to improve situations that are the consequence of the failure of the government to get the right policies in place, which is only making it worse eventually.
So some of it is about money, obviously. You always want more investment, but then a lot of this is about getting the basics right and structure them.
Yeah. It's around governance and culture of the NHS, how it's governed. Is the structure of the health boards right? Are they answerable to the right bodies? So at the moment, you've got the local health boards. You've got National Health Executive, NHS Exec Wales, HEIW, Healthcare Inspectorate Wales. You've got all these bodies, and none of them are answerable to anybody. And the government will say, well, it's not our gig, it's not our responsibility, it's their fault. Yeah. And so nobody's answerable to anybody.
I think there's a massive frustration, isn't it, both amongst patients, if you like, because we're all patients of the NHS, but especially amongst staff. I think staff can see what's not working. Yeah. They're feeling overstretched because there's not enough of them to do the work, and the work is increasing all the time. You know, how are we going to provide some kind of reassurance to staff that we actually have got a plan that's going to work for them as well as the wider public?
Yeah, I think that's one of the most important points. When you look at the NHS is nothing without that workforce. It's the workforce that keeps us going and makes sure that we are seen every day. But at the moment, there's no workforce planning. So we need a structured NHS workforce plan. We don't know how many staff we have for cancer, for instance, in Wales.
Really?
We don't know. No, we don't know. You'll hear the RCN saying that we are 2,000 nurses short. That's based on FOIs. But we're not clear how many nurses we have because they are banded differently in different health boards, whether they're community nurses or in the hospitals, so they have different titles. So we're not clear on any of these things, even though NHS staff account for something like a quarter of the whole Welsh Government budget. So it's a huge amount. And we have to look after them. So we need that NHS workforce planning to begin with. We need to make sure that we identify where the needs are in the community. So when we look at GPs, we've said that we would employ an extra 500 GPs over a 2-term period, so that we've got workers and staff in the community. In order to help GPs, we've got a plan for that. We might get into later on. We're looking at contracts. Crucial. We're always talking about funding for staff, but a crucial element is the contract that they work to, be that dentists, be that nurses, be that radiologists. So that they can have the continual professional development during working hours. Yeah. That they can improve themselves.
And there seems to be a real inflexibility. You know, we spoke to a dentist in Coedpoeth who reluctantly handed back the NHS contract, but wanted to keep it for under 18s. And the Health Board and Welsh Government wouldn't countenance that. And you're kind of thinking, well, hang on, we need as much dental care for especially under 18s as you can get. And to sort of brush that off just struck me as a kind of very kind of just a sort of dismissive attitude. We know best,
Yeah,
almost.
yeah.
And these are the guys delivering dentistry.
Yeah.
And I think, speak to any nurse, and I do on a regular basis.
I bet.
And they will say flexibility of contract is what drives nurses to go to agencies.
Yeah.
And that so that they can pick what shifts they do. If the NHS was offering that element of flexibility, I think you would see a huge difference in terms of retention and staff morale.
Yeah, I think you're right. We're talking about recruitment of staff every time, but retention is far more important.
I think so.
Something, not only if you have retention, then you've got the staff that know the area, they know the patients as well. So there's that relationship, but then it brings other people in as well. So you keep that skill and bring in new people. Dentistry, we're talking about the NHS dentist contract now, and there's reforming of the NHS dentist contract. This has been an ongoing sore for dentists since 2018.
Really?
And before that even. We're talking here, this is how long it's taken this Labour government to actually take it seriously and think, right, we're losing dentists left, right and centre. Maybe we need to look at the contract. They've just ignored the dentist's demand. And the BDA, the dental body, they've been locked out of negotiations with the Welsh Government since last October.
Really?
Yeah.
Stop talking to them.
No.
Oh, wow.
So the BDA, representing dentists, don't even know what's in, or they didn't know until the consultation, what was in the new proposed contract.
And this is a situation where I'm sure I've seen a figure. Is it something like only 36% of people in North Wales have got access to an NHS dentist?
Yeah, something
and
like
we
that.
won't talk.
Yeah, honestly, if you talk to the BDA and if you talk to dentists as you've done, there is a real threat here that we're not going to have NHS dentists left in Wales within 5 years.
Yeah, it's going.
That's serious.
As things stand, it's going.
Yeah.
One by one, they're all dropping off.
And dentistry is sort of a symbol of the wider health problems.
Yeah.
In my area, for instance, we're seeing dentists leaving, as we've just touched on, but they are turning to private dentists.
Yeah.
They're giving or suggesting that patients pay £30 a month.
Yeah.
And then as part of that contract, if they pay an extra £10 a month, they can get to see a doctor as well, a GP.
Oh, really?
And the GP will provide a half-hour service rather than just a 10-minute slot. People go for that then. Even though they probably can't afford it, they go for it because of that security that they're going to see a GP. This is privatisation of health under Labour.
Yeah. We've got a doctor in Rossett, a private doctor in Rossett, offering 30-minute consultation, £125 a shot. So the worried well can see a GP any time of the day, basically. But if you've got a problem and you haven't got the money,
no, that's it.
You're up the creek, aren't you?
Yeah. Not just if you haven't got the money either, but you still have to pay for taxis to go and see if you're elderly, especially. So it's costs. So yeah, we're seeing the privatisation of health at the moment.
So what are we going to do about the dentist situation? Let's start with that then.
That's pretty simple. Nothing is simple, but with dentistry, it's looking at the contract, working with the dental workforce, finding out what works for them.
Talking to dentists.
Literally talking to dentists and taking on board their concerns. Now, the Welsh Government are right that they need to reform the current contract. We've known that, as I said, for years. But how they reform it. And the current proposals mean that we're going to lose that family dentist. Dentists aren't going to be able to see patients continuously because patients will be able to choose which dentists they go to see, but there's not going to be that consistency of care.
Yeah.
That's a real concern. So we're going to reform the dental contract. We're going to make sure that we have dentists going to schools again so that children are seen at a very early age. That's
important.
It's part of the preventative agenda.
Yeah.
Deal with issues early on, especially in the more deprived communities, where we know we've got a lot of problems with dental hygiene, and also ensure that children get a toothpaste and toothbrush, and that in school breakfast clubs that they then learn how to brush their teeth properly. Simple, basic steps we need to go back to again.
Okay, I mean, the other big issue for us, and everybody knows this, is waiting lists, isn't it? It's around 800,000 people in Wales on a waiting list at the moment. So getting those down, Labour are trying different methods in terms of how they're trying to do that. We've had a bit of a chat about this previously, haven't we, in terms of waiting lists. But how are we going to make some serious inroads to those waiting lists and get them reduced.
Yeah, waiting lists, it's a huge political issue, and I understand why, and we all know people on waiting lists. My wife was on a waiting list for 6 years here in the Mailer, until someone said, oh, there's a waiting list in Ysbyty Gwynedd Bangor, that's only 3 months. Would you like to go over to Bangor instead? You're the same health board.
Yeah. Is that because they're not even within the same health board? They're not talking to each other?
With Betsy, that's the problem. They are still 3 health boards.
Wow.
They're not talking. That's why what you had happening in Penley, the management didn't even know about it.
No, exactly.
Because they made their own decisions in their regions.
So East, West and Central are just not cooperating.
They're not talking properly with each other. They're not sharing resources. They're still standalone units, or they have been. To be fair, they're trying to change that culture.
I can see a look.
Just because, that isn't about money, is it? That is just about
competence.
Governance.
Basic. You're not talking to each other.
That's back to that governance issue. The most basic of issues within the health. It's not the sexiest thing. I know, it's not something we can talk about on the doorstep every time about governance and culture of the NHS. But it's the basics that if you get that right,
what's going wrong, isn't it?
But if it means that somebody who's on a waiting list for 6 years gets seen in 3 months,
that's
I get that. It's an absolute game changer, and that's what we need to be sorting out, cutting through all the red tape, cutting through all the bureaucratic crap, and actually delivering for people. Whether it's seeing your GP quicker, getting through A&E quicker, getting discharged from hospital quicker. All these things are interconnected.
Yeah, exactly.
And it's a managerial problem as much as anything.
And that's part of our response of our 5-point plan to tackling the waiting lists, which is making sure that health boards share resources and talk with each other. So we've got this postcode lottery in Wales still, where in my region, for instance, the area I represent in Dwyfor Meirionnydd, let's say you're in the south of Gwynedd, you're in Dinas Mawddwy area, or you're in Tywyn area, your closest hospital is Bronglais in Mid Wales, in Aberystwyth.
Different health board.
It's a different health board. So they're driven over to Ysbyty Gwynedd or to Wrecsam simply because it's in the same health board. Or if they are sent over to Bronglais, then the notes from the clinicians in Bronglais spend longer to come back to their GP or back to the health board that they reside in. Because you've got these legal structures that are standalone legal structures and they're not.
I was going to say, why does that take so long then to send notes? Is it going by carrier pigeon? What's wrong?
It's basically going by taxi. It's paperwork.
So why don't they email it?
That's digitisation. That's a huge problem we have in the health service. We might want to get onto that.
Email stuff?
No. Sometimes they do, but different organisations, even within the same health boards, have different software. So these pieces of software don't talk to each other. And it's part of that culture that they're still part of the old 1970s, 80s model of having a dictaphone, speaking into it, getting someone to write it out, print it, put it in the post. By the time all that gets through.
Yeah. That's shocking. That is quite staggering to hear.
We know we can do without all of that. We know that AI is... we've got AI technology that can do all of that in an instant. They're doing it in London. They're doing it in other places, but we're not doing it here.
It's beyond belief. It really is. Wales is a relatively small place.
Yeah.
It's 3 million people. You would think that you had one system within the entire health service that talked to each other. And to learn that GPs can't talk to their own health board, in the same system, and let alone other health boards, it's just beyond staggering. And so which ass needs kicking to get that? Sorry, there's a lot of work.
National Health and Care Wales, you'd think that body, a national body looking at the digital infrastructure, would actually say,
hang on, we've got a body that looks at this.
Yes.
And we're still sending paperwork by taxi.
Yeah, and faxes are still being used.
Faxes.
Yeah. You know those machines, in films.
All my time.
Yes.
Yeah. You don't even remember faxes.
Yeah. So I went up to see. There's a body in London called One London. Now London is a big city, right? Yeah. And within all the people that work there as well, it represents some 13 million people. So you've got a load of NHS organisations there. And they decided, they didn't wait for political leadership. They decided that the patients expected them to work together and to have this sort of digital infrastructure.
Yeah.
So they set up One London. And over an 8-year period, it cost them £42 million, right? Just 42 million to build the APIs, the sort of central piece that makes one computer talking to another computer. That's the sort of central part. They didn't build a new infrastructure, digital infrastructure from scratch. They just connected the current one. So you can buy them off the shelf. You can buy pieces of computer and take off the shelf, just get them talking to each other. 42 million. They've done that. So the NHS in London is now seamless, digitally wise. And they're on to the next step now of making sure that people are health literate, so they can have a fantastic app where all the information is on that app, and they can share it with their podiatrist, or they can share it with their radiologist, or with a GP, or with a nurse.
Yeah, we said we weren't going to talk about digitisation because it was boring, but actually it's
critical,
absolutely critical to have that information on hand.
Yeah.
You know?
If we are talking about efficiency savings, if we're talking about a more efficient NHS, if we're talking about the fact that we're probably nearing the peak of our staffing in the NHS now, we can't get much more in. We're on a sort of Scandinavian level of numbers. Then in order to get it more efficient, get those staff to do the work that they want to do, we need to get the digital infrastructure right.
Yeah.
Okay, so we need to talk to each other.
Yeah.
What else is in the 5-point plan?
Well, the telemedicine is a simple one that's been going on for decades. We've had telemedicine across the world for the last 30 years.
What is it?
Well, you can talk to people like this. So you can have a patient at home talking through currently Zoom or some other software.
Online appointments.
Online appointments where you can have a GP or a clinician check in on you, making sure that the symptoms are all right, talking to you basically face to face. That can be done, especially in rural Wales, where we've got transport issues. That telemedicine would save a lot on the waiting lists. So you could take people off the waiting list if you had telemedicine, because you can check in on them.
I'm going to push back on that. What if, a lot of people go to see their GP with I've got a nasty cough, but actually I'm depressed.
Yeah.
And you don't you get the body language very quickly face to face.
Yeah.
If you've got telemedicine, you've got a Zoom and you've got your 8 minutes, you're going to go, I'll give you some, antibiotics or whatever.
The thing with telemedicine is to check in on that patient. It's not a new diagnosis.
Okay. Fine.
So if a patient goes to a doctor with something new, the advantage of having a family doctor, not a locum, nothing against locums. I understand why GPs want to become locums because of the flexibility we talked about earlier. But if you have a family doctor, they will know that patient.
Yeah.
And they will be able to identify, look, there's something deeper going on here.
Yeah.
So those new diagnostics on new patients, you need that face-to-face.
Yeah, good.
But you need more than 10 minutes.
Yeah.
But that's another matter. So telemedicine is absolutely something. Local treatment centres.
Yeah.
At the moment, if you have to go and get a new hip, for instance, you're on a waiting list for months, if not years, in some instances, waiting to go into a hospital, waiting for that slot to come up in the theatre. Well, we can make sure that, as we're seeing now being rolled out in Llr, you have that treatment centre, which is a standalone centre, but the only thing they do is treat those orthopedic issues or
just the less complex.
High volume, low complexity issues, cataracts.
Yeah.
It's like a factory. Basically, you can get the expert in there, the specialist who's been specialising in that field for a number of years, and they can treat multiple patients in one day.
Okay, that makes sense as well.
So temporary treatment centres is what we need. Set them in, like we had during COVID. Set them in, get people in and out, and then once we go through the backlog of patients, then we can go back to the old standard regional hospitals.
Yeah. Okay.
So that's one of the other points on getting the waiting list down. The other one is what we call an executive triage. Now, that's a posh term. Yeah. We all know what a triage is. So you assess the needs of the patient. A lot of patients, believe it or not, don't have to be on a waiting list. So we're going back to this issue of we don't have enough GPs. And when you don't have enough GPs and when you have locum GPs, without the time to look at a patient, more often than not now, they will say, well, okay, not quite clear what's going on here. It could be this, that, and the other. You need to go on a waiting list for the treatment. Well, that patient doesn't necessarily have to be on a waiting list. They might need to see a therapist. They might need to see a nurse. Right, so there's one stat that struck me in Bevan Health Board in South East Wales. Some 40% of the paediatric patients don't have to be on a waiting list.
Yeah.
They can be taken off that waiting list if they see the right clinician or the right therapist.
And could that work in an A&E sense as well? Because at the moment, you know, A&E in Wrexham anyway is an absolute basket case.
Yeah.
And I think there's a real danger that people don't go anymore because they think they'll be waiting there for hours and not getting seen. To what extent could you speed up the triaging system there or make it better so that people are getting the throughput?
Yeah, the thing with an executive triage system, it will be relatively expensive because you'll need a clinician to sit above everything and assess everybody's needs. But that's an investment in making sure that people get off the waiting list if they don't need to be there. If you go to Wrexham Mailer or any hospital and go to an A&E, there's an issue there that people go to A&E because they can't access GPs.
Yeah.
Because those GPs don't have enough time with the patient, so maybe they're diagnosed wrongly or they don't get the full diagnosis that is required, so that they go back into A&E. So we need to resolve GPs, community care. Earlier.
Actually, it goes back to your first point, though, doesn't it, about workforce recruitment? What's really frustrating to hear is how long have we been talking about a failure to plan for workforce recruitment? It's more than a decade ago we were talking about this same thing. So it's really frustrating to see that this is still the conversation now. We need more doctors.
Yeah.
What is the plan to recruit those doctors? We're clearly not going to get it from Labour, but obviously we need to think long term.
Yeah, so we've said we'd recruit an extra 500 GPs over a 2-term period. Now, that 2-term period is pretty crucial because you can't train GPs within that 4-year SINF term.
No.
So realistically, it's going to take 2 terms to get them in. The good news is we're already training 400 doctors in Wales in that cycle of training doctors. So potentially we've got 400 doctors waiting.
If they stay.
Yes. Currently they're not staying, and there's a reason why. So in some parts of Wales, we've still got the golden handshake, where we provide funds to a new GP to stay in the area, and that lasts 2 years. Okay, there's merit to that, but that only delays a problem by 2 years, because once that money goes, then a GP will go to Australia, New Zealand, Canada, or elsewhere. Why aren't they staying? There's a number of reasons why, but one of the biggest reasons is that we've got a number of GPs now reaching retirement age, and they are tied to a contract for their practice. So most practices are rented, or they're on a hired service, or that they pay a huge amount of funding, money for it. And that contract ties them in for a period of time. New GPs don't want to come in and tie themselves down to that contract, knowing that the only other GP in that practice will be leaving in 5 years and they'll be lumbered with that GP practice.
And bottom line is most GPs don't want to be business people, do they? They want to be GPs. They're trained as doctors. Why do they want to spend all day doing paperwork and employing people and what have you? You know, I think you're trying to weld 2 things together there, aren't you?
Exactly. So what we've said is we need to find a way of dealing with some of those basics. Why aren't GPs staying? Because they don't want to be lumbered with that massive rent. So we'd set up a fund in the Welsh Government to help resolve that and pay for improvements of some GP practices, because there are more demands on GPs now. There's not enough space in a GP for a therapist or a nurse. So we'd help improve the GP practice and cover the cost of the lease or the rent, so that they aren't burdened with that and they can do the work that they need to do. That would help retain GPs, something chronic. It'd be great to see those GPs then stay and then get more into the system via the 400 that have been trained at the moment.
I'm thinking of a particular surgery in Hanmer, which is operating out of a shoebox, basically.
Yeah.
And they've been working now for 10 years with the health board, more than 10 years, to try and get a bigger surgery so they can have two GPs, you know, to meet demand, to be offering more services, to be training students, all these extra things that this very good GP wants to do. And it keeps getting blocked.
Yeah.
And they're basically quibbling now over 30 square metres. And you're thinking, if you'd have done this 10 years ago, it would have cost half what it's going to cost now because of rising costs.
Yeah, exactly.
And you just think there's a bureaucratic block to people who want to provide a better community service.
Yeah.
And rather than him bang his head against a brick wall for the past 10 years, he could have been treating hundreds of people.
Yeah, I could have employed a nurse, an extra nurse to come in and everything.
Yeah.
What's frustrating with GPs, and I must feel for them, you know, the government have changed the way that your GP practice works now. So they'll say, well, if you've got these illnesses, go to your pharmacist. Or if you've got these illnesses, go to a therapist or go to other people except for your GP to try and lessen the load on the GP. Okay, but for the GP, the truth of that is they no longer see your colds and flus and your other sort of light issues. They constantly see the heavy issues. People going in with heart disease or cancer or COPD, really heavy stuff that they need to deal with the patient. So the mental health of the GP is shot because they don't get that space of rest at all.
They're not doing any fluffy stuff, are they?
No, the sort of downtime that they get to gather their thoughts, none of that is current anymore. You know, they can't do it.
Yeah. And as you said, you know, we need that preventative agenda because we're as a nation we're getting worse in terms of healthcare. Well, we're getting older. Poverty is a thing.
Yeah. Well, thanks for reminding me. The other part of the GP contract that we'll have is we'll shift the funding within the health service to be more in that primary care. So at the moment, something like 5% of the NHS funds go to primary care, go to GPs actually, where they do 90% plus of the work.
Yeah.
So we've said we'd get that back up to the 8.8% historical levels. We'd like to see it up to 11%, probably unrealistic currently, but we'd shift the resources to that primary care element.
Can't talk about health as well without talking about social care. And we've had a long-standing policy of integrating health and social care. What are your thoughts on how we're going to go about doing that?
Yeah, we need to make sure that health and social care are completely integrated because at the moment we've got far too many patients who are falling between the gaps between local authority and NHS, people unwilling to pay or take responsibility, and we're seeing parents and patients listening to debates and arguments between local authorities and the health board saying, well, I'm not going to take responsibility because it costs too much. And a value is put at the health of their child, for instance. That's wrong. So we need to see merging both of them. Now, that's going to be difficult. They tried to do it in Scotland. They've had to roll back a little bit. So we're looking at ways of making sure that we keep local authorities as part of the delivery partners, that it's commissioned via local authorities, but that it's delivered by NHS, because that's where the money's at. So that we're making sure that there's complete integration between the health and social care. If it's commissioned by one but paid by another. But the most important part is paying social care workers far more than what they're paid currently. They're paid minimum wage at the moment for really heavy work, really intense work. We're seeing people leave the sector, going to work in Tesco's and other places because they just...
It's the same money.
Yeah.
Less stress.
Better.
Yeah.
If you're working in Aldi's, it's better money. You're being paid more than looking after someone, keeping someone alive.
Yeah.
So we'd increase the wages.
But it feels to me there's more than wages, though, isn't it? It's almost like respecting what they do and treating it as, you know, because healthcare professionals in whatever level they're at in the health service, they're treated as healthcare professionals. In the care sector, they're not treated in the same way, I don't think, and there needs to be an equalisation there in terms of respect as well as pay. You know, and see it as a profession, see it as a career rather than something you do if you can't do anything else.
Our long-term ambition is to bring the care workers in on the agenda for change contract that nurses are on.
Yeah.
Now, there will be some issues there where we have to figure out the differentials in pay, but that's the principle of the direction that we want to go in, and making sure that they are shown that respect that they deserve because of the work that they carry out.
Okay.
I think we spend a lot of time obviously knocking doors, you do as well, Mabon, but I think there was a sense of hopelessness, or there is a sense of hopelessness around health, that it's just deteriorating and it can't be fixed. I think what will reassure people is listening to that it can be fixed. It's not actually all about money. There's cultural change needed. There's structural change needed. There's some basics that we need to do. I thought digitization might be a bit boring, but now you've explained that we can't necessarily even email between health boards. That's quite shocking. So I think what you've set out is going to give people a lot of hope for the future, that there are things we can do, and the Welsh NHS will work once you have the right people in charge.
If we have a Plaid Cymru government next year, people will live better longer as a consequence of the things that we will put in place in government. That's the short of it.
Diolch yn fawr.